Welcome again to my kitchen and our kitchen class actually, and have a cup of coffee, and we'll share some ideas again today. I look at today as kind of a tying up ends today, with next week where I demonstrate dressings. The week after that, how long, catheterization, and the weekend after that, central venous lines. So I should have all the equipment by then. It's been a little difficult getting it, but I now have a source that I can at least begin demonstrating and showing you things. I think I'll start first. I'd like to talk about the nursing diagnosis today, which is very important. Now, when you go in the hospital, there's your diagnosis, whatever it is, pneumonia, cholecystectomy, whatever your physical diagnosis that the physician has given you. A diagnosis that they can get insurance back, right, Joe?
Yep.
It has to be a certain code for the hospital to be paid by the insurance company. So that's another whole area of how that's put in. But there is also what's known as a nursing diagnosis, which is crucial to you, and it's something you should know when you're in the hospital, and you should ask for. Now, I remember, I've been around long enough, I remember when the nursing diagnosis was what just began. And it's not the physical diagnosis, it's the patient's response to the illness. Do you see the difference? It's a very, very important. And I remember in the beginning nurses were, oh, extra thing I have to do. But it's extremely valuable to nurses. In the beginning, the nurses had to write it out themselves. I believe now there's probably something that's on forms, it's all standardized.
Electronic medical records.
What?
It's electronic medical records.
What, the nursing diagnosis?
Yes, I think so.
Well, the nursing
They're always with their,
Well, it's a part of the, I'd like to talk about the medical records that are on. We'll do that, Joe, because I want to. Nursing diagnosis is something that the nurse uses at the bedside, and it probably is on the computer now. I mean, everything else is. When we used to have to write it ourselves, it was great individualization. Now, I'm going to give you a nursing diagnosis so you understand why it's so important. If there's one that's standardized on the computer, fine, the nurse will tap it, but it should be individualized, because every patient that's in the hospital had individual needs and is responding in an individual way to their illness. So I'm going to give you an example. I put it in the book, and I think it's the clearest example of what a nursing diagnosis is, because to me, the nursing diagnosis is a weapon you have to fight the illness. So I've listed it under one of the weapons for the illness. Okay. It was developed to document the patient's response, a statement that describes the patient's actual or potential response to a health problem. So the patient in room 553 is not the cholecystectomy in room 553. It's Mrs. Atkins who has the following nursing diagnosis. Ineffective airway clearance after surgery related to incision pain. Mrs. Atkins cannot take a deep breath because her surgical wound hurts so much. If she doesn't breathe deeply and cough to bring up mucus, she could develop a pneumonia. Make sure she has the proper pain medication so she can cough and deep breathe. Okay, she's not just a cholecystectomy. Maybe other people with cholecystectomies have no problem coughing and deep breathing, but she does. Feeding self-care deficit related to previous cerebrovascular accident. Mrs. Atkins is in for surgery, but since they suffered a stroke previously, she's not able to use her hands to feed herself. Make sure there is someone who can help her, and possible referral to occupational therapy. Okay, just make sure, and this is on the record, that you're going to make sure she's able to eat properly. Maybe she can feed herself a little bit, and she needs help with opening everything up, getting it set. And this could be a good time to have another refer to occupational therapy or physical therapy. Social isolation related to age and lack of family contacts. Mrs. Atkins does not have regular visitors or potential caregivers at home after discharge, contact social services to see about social supports, perhaps volunteers or possible church groups. Okay, you want to you as a nurse are proactive to make sure she has contacts in the hospital, but also she's prepared for discharge. And it's a good way to do that while she's there. It's a time to do that. And then you might add to the nursing diagnosis as things come up that are related to her response to the treatments that you do. So what you need to do, if your mother's in the hospital, if your husband's in the hospital, if anyone in your family is in the hospital, ask what the nursing diagnosis is. It's a simple question. I mean, it's not a hidden thing, but you have a right to know, and you have a right to maybe have a copy of it or understand, because you want that individualized for your mother or your husband or your child. This is an important thing that I don't think people know about all the time. So put that down in your mind, write it down, do what you can. Did you know about the nursing diagnosis, Joe?
No. I didn't.
He doesn't.
I thought discharge planning does this.
Well, what about in the hospital? Discharge planning does. See, the nurse is the one that pulls it all together. The RN is trained to pull it all together. She's not just going to refer to discharge planning. Eventually she will when the time comes. That's a whole thing. Discharge planning is another thing I'd like to look at in detail. But don't get me off the track unless you want to talk about it now. I think I will talk about it now because Joe brought it up. Why not? Discharge planning is supposed to start when the person is admitted to the hospital. Okay, that's what the nurse is taught. Not when they're ready to go, but you think discharge planning right from day one. They come in from the emergency room, they come in for surgery, you think discharge planning, okay? So everything fits together. What I'm hopeful that as you learn about the standards of care, that will help you when the discharge planning begins. Lots of times you're being discharged from the hospital and the nurse gives you a sheet of paper with instructions. And she'll say, absolutely, if you have any questions, be sure to ask me, you know. And if you're going home with more complex equipment or anything, there'll be more in-depth learning or teaching. Let's say teaching, not learning, because there is a difference. You're going home from the hospital, you're nervous, you're anxious, you want to get out of there as quickly as possible. It's somewhat overwhelming, everything happens. So my point of this book, one of the points of this book, is you're starting to learn about the treatments. You know, you recognize that if there is some sort of, you're going to have IV therapy when you're home, you know about what happens if there's an infection. You know that ahead of time. You got a little bit of a heads up before the discharge. I read somewhere in research that only about 30% of the doctor's orders are followed by the discharged patient. So, you know, there's something in communication there that needs to be stronger. That you learn, you're not just taught, but you learn. And oftentimes, when you're being discharged, it's a hurried thing. You know, the nurse has got 5 people that she's discharging, and she'll always say that. If you need any questions, let me know. But you don't have questions. And when you get home, let me know. But it's a kind of a process. Does that hit you with discharge planning?
Yeah, when I was in the hospital, nobody told me about discharge planning.
You know what they did? They figured you were a doctor. You didn't need to know. But you need to know as much as anybody about discharge planning. You know? They did refer you to, I remember they referred you to occupational therapy, right, or physical therapy. Because you were weak after 5 days in the hospital. I remember that. But you don't remember any discharge planning.
No, I was a basket case.
He was pretty bad. He was very weak after that hospitalization. So, you know, discharge planning is very important. I'm glad you brought that up, honey. That makes sense. But we'll switch back to nursing diagnosis. You remember, you ask for that, okay? Now, last time I was with you, we talked about intravenous therapy, right? And I looked through my notes, and I realized I didn't mention that the nurse is supposed to, on the what's keeping your port in place, she's supposed to put the date and the time and her initials. His initials, okay? And I didn't mention that. That's very important, so they can keep track of when it goes in and when it needs to be irrigated or changed or whatever. So that's very important. I think I covered IVs very well. I might bring them up again a little bit. We're going to talk about them when we do central venous lines and peripheral PICC lines and like that. So that's coming up if you want to stick around with me. Now, the other thing, I did talk to my beautiful granddaughter, Julia, and I talked to Kelsey too. Julia is starting clinical. So I wanted to be sure what I'm teaching as a clinical instructor is what she is being taught. So it was really a nice conversation when we had. So the one thing she told me about the ventrogluteal shot. Remember we did shots and all that. That's in your butt. That's in your butt. I said we taught it as you make the cross and you go the inner aspect of the outer quadrant. It's the same thing she's taught. It's called the ventrogluteal IM shot. She is taught to put her palm on the trochanter, the bone back there, her fingers on the iliac spine, and then she opens up her fingers like this and the shot goes there. Now you don't have to know that, but you know that there is care taken with one of those shots, okay, right from the beginning. And it's taken because they don't want to hit the nerve, the sciatic nerve, or any blood vessel or anything like that. So it's very important. So you say, it comes back to what do you say? How do you know where to give that shot in my rear end? It's not any invasive type of question, but it's interesting to bring it up into the forefront because it's not just, and then they should tell you, well, we do this and we do that and we measure that. It's easy for them to say that as they do the procedure. That brings me to another point. Did I talk about people saying I don't have time for that? Courtney, Joe, I don't want to repeat myself, but...
The nurse?
Well, just when you're asking these questions, it takes no time away from what is being done to talk about what you're doing. You cannot expect the nurse to sit down with you and explain all the dimensions of what she's doing. But there is no reason that any caregiver can't talk about the procedure they're doing as they're doing it.
No, I don't think
Remember that, because you might get, I don't have time for that. Oh my God, how can they ask me to do something else? I'm not presenting anything that's going to add to the time of the caregiver. It's just going to help focus. Did I talk about that before?
No.
I don't think so, because that's very important. And I want to tell you how I taught, and I don't think I told you either. For the 16 years I was in the hospital with student nurses, Nursing 101. What I did when they were taking care of a patient, I went in first and asked the patient if it was all right if a student was caring for them today, and that I would be with the students. Most patients kind of liked that because they were getting two nurses. They knew they were getting a clinical instructor, and they didn't mind being, in a sense, a part of the process of learning. Then when I got there, I looked at it as a dialogue between three people because the student was nervous. I'm there evaluating them. And when they're nervous, they're liable to make mistakes. I didn't want that to happen. And I wanted them to learn not only the steps they do, I wanted them to learn why they did it. That was very important to me. And I didn't want the patient just laying there. I invited the patient to share, or the family who was there, to share in a kind of bedside dialogue that made, I thought, for good learning and also respected the patient. Okay, that was very important for me those 16 years. And it seemed to be an asset. It was an asset for learning. And it was an asset for the patient because they were able to learn too and feel less a object and more cooperative. So that's what I believe that teaching should be. So I know that as procedures are done, you can talk as you do the procedure. You can teach as you do the procedure. So I want that, because people may say, oh, you can't. You're adding to the nurse's job. You're not. You're facilitating the teaching part of the job. Okay, what else did? Oh, here's something Julia told me. With the computers, we used to have that medicine cart that would be pushed around. There was a little drawer, and each drawer had a patient's name on it, and in the drawer was the medications. Probably still done in a lot of hospitals if they haven't been computerized. Now where she's practicing, she goes into the computer, she puts in she said the patient's name, she types in, and the drawer opens, which is kind of neat. I would think that maybe there would be less. What do you think, Joe?
Whatever.
Whatever. Oh, he's very, whatever. Okay, if you have an opinion, jump in. But I thought that was interesting, and it could, and the pharmacy obviously fills the drawers, I would assume. But she's been taught those 5, remember I told you about those 5 things that they have to check on. Right patient, right medication, right time, right dosage, right route. Last time we did that. They do 10 things now, she said, but it's variations of those 5. And I didn't actually ask her what they were, but they were kind of variations of those 5. They also are taught what is called the 3 bedside A's, which are neat. Armband allergies assessment. Now they're all things that we taught when we were teaching, but we didn't put it in. It's easy to remember when you have these kind of, what do you like? You like mnemonics?
Yeah.
Is that what it is? What's your favorite one you're always telling me? Robid, what is it?
An old Olympus tippity top.
Was that the one for
Cranial nerves.
cranial nerves? So he's one, he throws that out a lot of times about cranial nerves. But it's good to put them in learning. I'm talking about learning here. It's good to put things together in a little package. So basically they check the armband. Now we put it on scanned, okay? They always ask about allergies. That should be asked on admission. Sometimes people forget. Oh yeah, right, I got some penicillin about 10 years ago and I did get a rash. I forgot about that. So you always ask for allergies. And then you assess. Now my big thing has always been assessment. Always monitoring, always watching, always seeing if there's any reaction. So I thought that was kind of neat. I enjoy, and she told me if I want to get more people hearing this, I should make a link on Facebook. So I'm going to do that because if I'm sharing this, I want to help as many people as I can. And I'm in a new ball game here, so Courtney and I are going to figure it out. Okay, now that takes care of. How about emergency rooms? I got my new thing to work on now, emergency rooms. I made an assumption that all emergency rooms follow certain standards. Because of the emergency rooms we've had, the one we go in particular, I won't mention names, both Joe and I had to go there. And there is a standard of care that I assume all hospitals follow. I found out through my daughter-in-law that is not always true. So I think I'm going to do some more research. I got this form. This is from my emergency room. Remember I went with back pain and I thought I had neurological problems. They send you an evaluation of what they do. And it goes from how you get in, how they took you right away. But they also add personal issues, which I like. Degree to which staff cared about you as a person. Very important. How well did the staff identify themselves to you? How well your pain was controlled. How well you were informed about delays. Safety and security felt in the emergency room department. Information you were given about caring for yourself at home. So that is what I was talking about, is respect. My daughter-in-law and my son didn't get respect when they got to the emergency room. And then you identify very poor, poor, fair, good, and very good. Now, as far as I'm concerned with this, everything was very good. There's also a word you should know. It's a Joint Commissions of Hospital Accreditation. Write this down. Joint JCOHA, I think. I think there's an O in it, Joe. But it is a Joint Commission on Hospital Accreditation. And there is also accreditation, I'm sure, from, and I'm going to call this emergency room up and find out how they are evaluated for emergency room itself. Because if you're going to do, and I'm recommending this highly, wherever you are, you look into what the emergency room has to offer you. Vacations, locally, and it's a simple, before it happens, do it before you have to use it. Find out who their staff are. Do they have a physician on call? Is there a physician there? Do they use nurse practitioners? Do they use physician's assistants? And I'm gonna look into that more, because all the physician's assistants I've met up here have been very good, well trained. I'm not sure that's all over, because I don't know the training, and I think that's important for you to know, because it sounds good. Physician assistant, nice, right? That's got some panache. What has it got? It's got some ring to it. You think you're safe, but how are they supervised by the physicians? How are they taught? Is it 6 weeks in the hospital? Because hospitals like that sometimes. Or do they have a program? And are they accredited? Are they licensed? I know my other grandson is a licensed paramedic now. And it's very nice. But he had to go through a lot of training and a lot of examinations to be licensed as a paramedic. So how about physician's assistant? That's my job too, to do more research, but I'm presenting it to you as something you might be interested in, because the staff is the key to your care. Now, I've been doing a lot of, this was an ad, full-time ad in last week's New York Times, okay? We are patient advocates. What we see inside our hospitals is disturbing. We work together and lean on each other to get the job done no matter what comes our way, so that every patient gets the care they need and deserve. You're talking about 3 hospitals in New York City, and you're talking about a strike, basically. This is exactly, I'm teaching you how nurses are taught. There is nothing more frustrating to a nurse than having so many patients that she can't do everything she's taught with the care she was taught to do it. There is no question that is one of the major frustrations with RNs at the present time. So this is just New York City. Right now, because hospitals refuse to hire enough bedside caregivers, we are forced to care for up to 19 patients at once. When that happens, you, our patients, suffer. Now just think, in 8 hours, you got to keep track of 19 patients with varying levels of illness, with all their procedures, and you need to assess. That's an awful lot of patients. The American Nurses Association, I think, recommends 12, and don't hold me to that. But there's a safe number. And what do hospitals do? They cut on this area. They have budgets. It's a business. And they start to cut. And these are prestigious hospitals in New York City. I'm not going to name them now. And there may be, we are fighting for the health care that New Yorkers deserve. It's the New York State Nurses Association. So they have to do it there. What's happening throughout the country? And remember, so when you're interviewing, because if you don't ask for care, you are the consumer. I keep on saying that, but so you are the consumer. If you don't ask that question, how many patients are registered nurses responsible for? Remember I said that in the beginning. When you go in before you even go in that hospital, if you have choice. Even if you don't have choice, that's a question to the hospital. How many RNs? Are they on every shift? How many patients are they responsible to care for? Write that question down. Put it in your mind, because that's crucial. Okay, so these are my kind of odds and ends here. Talked about the IVs, the Joint Commission, nursing diagnosis, what Julia told me. Is there anything else, Joseph? I've been talking a lot. Is there anything you want to add to it?
I'm speechless again.
Okay. He usually isn't like this. I know I'm the mouthpiece of the family, but usually he has something to say. One other thing I read just recently, that the big thing is they computerized everything in healthcare, okay? $300 billion it's cost. This is the big thing, last 5 years, whatever. But they're still following it, and I have to find the write-up. I think it might come in the New England Journal of Medicine. Errors and infections have not decreased. At least this is a superficial read of it. And it goes back to my belief that computerization is only as good as the people who use it. There's no question about that. The programmers and the users. And I might have said this before. When I did my doctorate, tell me if I said this before. I don't want to repeat. When I did my doctorate, I remember one professor said, garbage in, garbage out. And I thought, hey, that's true. If the program going in doesn't meet the needs of the caregiver, then what you get out is not helpful, you know. And they were just talking about research and your doctorate. But garbage in, garbage out. So computerization isn't the end all and be all of everything. It still needs a caregiver that uses it correctly and also follow up with it. One thing, now you could talk about this. When you were in the hospital, remember the nurse came in with her portable, rolled it in, her computer thing, and he actually was he that took care of you most of the time. He jotted in everything on the computer. But what interests me, and Courtney, you gotta stop me on this if I said this before. What interests me is I went out, all the nurses were in little cubby holes. There were little indentations along the wall of the, did I say it before?
No.
So there they were, and they were typing in their little computers. These little parts of the hallway. Did you notice that? Well, you probably were too sick. He was too sick to do it. But I thought, well, there they are. They're doing what they have to do on their computers, but is that taking time away from the bedside of the patient? That is always my question. Does it, the balance, is the output, the cost, is it benefiting the patient? And I'm not sure about that. I'm concerned about that. So I'm going to do some more research there. I want to find that study about, and the other thing they found, and why they didn't know this ahead of time, all the medical data is now being hacked. It's not protected. I mean, didn't they realize that would happen? I mean, I'm not a computer expert, but if you put all that data, including Social Security numbers, and all the diagnosis and all that data out on that great big web out there, people are going to get into it. Why wasn't there something built in right from the beginning that prevented this? So we got another problem. So obviously I'm old-fashioned. I'm not that into computers, I guess. You can, old fogey, I guess. But I do think there's definite questions here in patient care that need to be answered. Safety questions. So I'm bringing that out. So, Courtney, questions or?
I don't have any.
Are we going to fit so people can ask me questions?
Yep, they can comment on these videos.
Okay, ask me questions or comments, anything.
And when we share on Facebook, they'll be able to reach you that way too.
They'll do what?
They'll be able to reach you through Facebook as well once you share on that platform.
Okay, so that's good because I teach. I need questions so that I know I'm reaching things I haven't said clearly, things people disagree with, things that they would like me to go further with. Research that needs to be done. You know, I'm going to do research on emergency rooms, and I'm going to do that.
What about your records, like for you to like if you were to get x-rayed or something and you wanted to have those in your hand and walk away from the hospital